guys. This is our group, and as you can see, we are learning ultrasound today. So while she's doing this, we're gonna ask questions, and she's also gonna explain to us what she sees.
So I'm gonna just simulate that I'm doing a right upper quadrant.
Okay.
And we kind of have a protocol that we follow. So our first organ that we usually look at is the pancreas, which is this kind of bright structure, what we would call a hyperechoic, a bright structure. And we use a lot of vascular landmarks to be able to identify the different organs within the body that we need to see. So there's her pancreas. This kind of looks like a little tadpole there. And then my next structure that I usually look at is the liver, which is the second largest organ in the body. So here is her liver. Liver's a very vascular structure, so in addition to taking what we call grayscale images, we also use a lot of color Doppler.
So what do the colors mean?
So red, so Doppler first of all indicates blood flow. It indicates that something is moving. In this case, red means that it's moving towards the transducer. I use my little color scale here. And blue means that something is moving away from the transducer. So for instance, this is her main portal vein, and it's going towards my transducer. It's taking blood flow up into the liver, whereas this is the IVC, or the inferior vena cava, so it's taking blood flow away from my transducer.
That's cool.
Yeah, we have fun toys.
Okay, I'm gonna ask you a question.
Sure.
What is the hardest part of your day-to-day life working as a sonographer?
The hardest part of my day-to-day life, I would have to say the hardest part for me is trying to do more with less all the time. You know, the department that I work at, we're short-staffed, we're chronically short-staffed, as are a lot of imaging departments, and I hate to make people wait, and I hate to rush through my exams that I do. So yeah, it just makes it hard. It's hard on your body, it's hard psychologically. I think it can lead to some unsafe situations sometimes, especially when you're trying to do invasive procedures with only one sonographer and one radiologist. I don't think that's a safe type of situation. So yeah, I would say that's probably what I consider the hardest part of my job.
Why do you think, why is sonography so limited in the amount of people that are in the field?
I think it's just like every other healthcare modality right now. I think a lot of people left during COVID. I think that, they're exploring other career options. A lot of people like to, work at home or work remotely now. I think people are still afraid of COVID and the long-term ramifications of that. And I just don't think that we've recovered from that fully. And I think it's gonna take a while until we do. So yeah, it's a tough situation right now.
Okay, can you give us a rundown of your daily exams in sonography and what you might see most of?
Sure, there's her kidney. Here, I'll label that too. All right, so my practice, currently I work in a general department, in a radiology department. So I do a lot of abdominal work, so livers, kidneys, gallbladders, spleen, pancreas, bile ducts, things of that nature. We also do a lot of GYN type of work, so female pelvic ultrasounds, pelvis or uterus, ovaries, early pregnancy. I do a little bit of OB work, usually more on an emergent basis, because most doctors have equipment in their own offices where they refer their own patients to do their OB work. So most of what I do is more emergent. So maybe the patient hasn't felt the baby move, maybe she's having some bleeding, maybe she goes into preterm labor or something like that. Or in early OB, worrying about ectopic pregnancy. Is the pregnancy in the uterus, or is it somewhere that it's not supposed to be, which could be a potentially life-threatening type of situation. In the general sonography department where I work at, we do a lot of vascular work too. So a lot of blood vessels, carotid arteries that take blood flow up to the brain. lots and lots and lots of lower extremity venous exams to make sure a patient doesn't have deep vein thrombosis, which is blood clots in the lower extremities, which again can be a potentially life-threatening type of situation if they break off and cause a pulmonary embolism, obstructing the blood flow or the vasculature to the lungs. I do some work in the NICU. I look at little baby brains because in the first few days of life, it's not unusual for those premature babies to develop bleeds in their brains. So we do quite a bit of that. Where I work at, we also have a pediatric ER as well. So looking for appendicitis in folks. So I guess that's one of the things that I kind of like about working in a general department is there's a wide variety of things we do. We do a lot of invasive procedures too, so thoracenteses to drain fluid off the lungs, pleural effusions, paracenteses to drain ascites, liver biopsies, thyroid biopsies. You know, no 2 days are ever the same. Big variety of the kind of things we do, so it never gets boring. There's their gallbladder too. Big black hole, which is normal.
Do you have one piece of advice you would share with someone that's interested in sonography, or what you might tell them to get into the field?
To get into the field of sonography, you know, a lot of science, you know, heavy on the science classes. You know, make sure that you keep your grades up. It's not the only thing that we look at, but that is important. Sonography is a very operator-dependent type of modality, you know, so if I don't see it, the doctor doesn't see it. So I think taking your time is important, not rushing through things, doing your due diligence for all of your patients, staying on top of continuing education, you know, because just like any other kind of imaging modality, sonography is always changing. So, you know, knowing what the latest protocols are, what we need to be looking for, being familiar with different types of pathology and disease processes, and, you know, just being confident, doing the best you can for every patient. And if you have questions or you need help, don't be afraid to ask questions. I mean, I've been doing this for a long time, but even when I worked in the vascular lab, I would still go get one of my partners and say, hey, I need another pair of eyes. Come look at this with me. And that's okay. There's no shame in that. So, yeah.
So, like, looking at this, it seems like really hard. Like, I have no idea, obviously. How long did it take you to actually, like, kind of
Get the
get
hang of it.
used to it? And,
So it's funny that
know
you
what
say
you're
that,
seeing.
because when I was in x-ray school, like you guys are, we did a 2-week rotation through ultrasound when we were seniors, and I was like, I don't see anything on that screen, and I'm never gonna do this, so I'm not even gonna pay attention to this, la 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 la, you know. Well, my motto is always never say never, because you never know where you're gonna end up. And I was offered a job to cross-train in ultrasound years ago, which at the time there weren't a lot of ultrasound schools, so that was really kind of the only way to go, was they cross-trained a lot of radiographers. And I wasn't going to do it. I was kind of scared of that. I was like, I don't know if I can do that, because I don't see anything on that screen. And a very good friend of mine explained it to me that once you look at enough things that are normal, when something is abnormal, it stands out to you. And I think the same holds true for radiography as well. And that kind of made sense to me. I was like, okay, all right, maybe I can do this then. So, you know, we really hit the normal anatomy, lots of repetitions, you know, just like you guys, we do thousands of hours of clinical education so that you can get a feel for what something should look like. And then, yeah, when it's not normal, it's going to stand out to you. So that's kind of how I got into radiography. I kind of went on the accelerated plan. They taught me very quickly, much quicker than they probably should have. I made some mistakes early on. Yeah, we all make mistakes, nobody's perfect. But you know, our students do about 2.5 years in the program, but they're also learning 3 different modalities: abdomen, OBGYN, and then either echocardiography or vascular ultrasound. So in order to get a good feel for two of those modalities, abdomen, OBGYN, I would say about 1.5 years. And then another year of clinical education for the specialty areas, echo or vascular sonography is a good time frame.
So since you do know both x-ray and sonography, what would you say was the most difficult or hardest part in transitioning from x-ray to sonography?
Well, I would like to say, first of all, that I'm very grateful for my radiography background, because I think it gave me a good understanding of a lot of different modalities, cross-sectional imaging, but most importantly, my patient care skills. Okay, my patient care skills are top-notch as a radiographer, I felt like. I think that's kind of a weakness of our sonography program. I'd like to see my students have more patient care experiences like you guys have. Probably one of the hardest things is that radiation physics and acoustic physics are just the opposite of one another. You increase the kV, you increase the penetration power of your x-rays. You increase the frequency of a transducer, you decrease the penetration power of your transducer. So it was kind of like, how do I wrap my head around this, you know, to make sure I understand two different sets of physics, and how sound waves versus x-rays interact with the human body.
Well, thank you for explaining that.
Thank
You are sure welcome.
Doing an exam on our friend here.
Yeah. Thank you for being my guinea pig here. Your liver looks lovely.
Thanks.
Gallbladder looks lovely.